evening. Thank you for joining me today. This is Dr. Emilia Ripoll. I'm a urologist and urological oncologist who has been working in the Boulder, Denver area for the last 25 years. This is our fourth and last talk on the whole protocol, at least for now. And needless to say, this is my favorite one. A lot of the other aspects of the protocol for men and women have actually come from my passion in helping men with prostate cancer. So thank you for being here with me. I'm going to try to give you a lot of information in about 30 minutes, but at least I'm just giving you a little bit of a taste. And what I was trying to show you with this picture is, guess what? There is light at the end of the tunnel. So if you are suffering from prostate cancer, if you are suffering from some of the complications from the treatments of prostate cancer, don't give up. There's hope. There's a lot of new things coming up, and hopefully I will be telling you a few things you may or may not already know. So when I discovered the whole protocol, or when I put it together, my goal was to create something that would keep me mindful of all of the different aspects that would contribute to male sexual dysfunction. And not all of it is going to be directly related to prostate cancer, but some of it, including hormones, might be. So the four things that I'd really like to look at is usually hormones, penile health itself, pelvic structure, which is more musculoskeletal, the effects of the nerves and the muscles and ligaments around the pelvis and how those influence erections. And of course, the neurotransmitters. We always say that we are what we eat, and I think we are our neurotransmitters. They really define who we are and how we respond to our life in general. So let's talk a little bit more about penile function. For male sexual dysfunction, we have to have four things that we need to keep in mind. There's no doubt that the nerves to the penis must be functioning properly, and those are extremely important. And those are some of the ones that are going to be directly affected by treatments such as radical prostatectomies, radiation, cryotherapy, etc. We know we have the two neurovascular bundles, which travel through next to the prostate, outside the prostate, but next to it. And those usually suffer at the time of treatment. So we're going to talk a little bit about that and what's new on it and how can they might be prevented. Also, blood circulation, as you can imagine, is going to be extremely important. A lot of the blood circulation is not just having to do with prostate cancer, but some of the comorbidities that go with it, and also some of the other medical problems that people have before they develop prostate cancer, or at the same time, things like high blood pressure, things like high cholesterol, diabetes, etc. A lot of the medications that are being given for these ailments are also going to affect function of the penis. So we need to be mindful and aware so we can try to work with our primary physicians and see if they can change the medications and help us in this matter. The veins must be able to trap and keep the blood inside the penis. It's not just the blood coming into the penis, it's also the venous system, which is usually the one that carries the blood away. If you have something that we call venous leak, meaning that the veins are not shutting down appropriately, of course, you're not going to be able to maintain the erection. So that's one of the reasons why people may get a good erection but are not able to maintain it. There's also, of course, as you can imagine, there must be the right stimulus from the brain. And I'm not just talking about neurologically, but also if you're exhausted because the hormones are out of balance and you're not able to have the desire to have everything that goes with that, you're not going to be able to have an erection. So let's look at how these things can affect people and how can they be circumvented. One of the things that I wanted to talk to you about, which has been a major part of the whole protocol, is using platelet-rich plasma. Platelet-rich plasma is something that we can get out of your own body, out of your own blood, and therefore we can concentrate that. It's not from the outside of your body, it's not a chemical. And the beauty of something that is autologous, which means coming from you, is that the chances that your body is going to react wrongly to it is very minimal. So the complications are extremely rare. A lot of people say, what? I have never heard of platelet-rich plasma. The truth is, it's been around quite a bit, and it was first used in 1987 by cardiology during a heart transplant, and also it's been extensively used in orthopedics, and a lot of people are using it instead of joint replacements. The nice thing about it, once again, is because it is from your own body, is not causing any side effects. So the worst thing that can happen is that it may not work, but at least it's not going to harm you. This is just a little bit, just to kind of give you a little bit of the concept of how we actually can separate the red cells from your plasma, and from there we can get the area that concentrates all the important growth factors, and those are the ones that we usually use in our treatments. The cool thing about the PRP is not only that it's bringing growth factors, but it actually has a way of also calling, you may say, or bringing in stem cells. The shot that has been popularized by Dr. Reynolds is called the Priapus shot. And essentially the Priapus shot at the beginning was a way of using the platelet-rich plasma and injecting it into the corpora cavernosa in the penis itself. That has been extremely useful in men who do not have prostate cancer, and in some cases, it has been useful in men with prostate cancer. That being said, there has been some very important modifications that have been developed, that we have been trying to develop in order to address the special needs of somebody who has gone through radiation or radical prostatectomy. Because one of the concerns that we have sometimes, some people say, oh my goodness, what about putting stem cells, or what about doing, adding, growth factors to an area that is closely associated with cancer? Is that a smart idea? Could that down the road cause, more problems? The truth is that we don't believe that's the case, and there is nowhere in the literature so far that has ever documented such a thing. But on another technique that we have been very excited about is shockwave therapy. Shockwave therapy has been used, or a similar aspect of it, the high-intensity one, has been used for breaking up stones in the urological fields forever. We've been using that for the last 30 to 35 years with extreme success. We later realized that if you used, instead of the high-intensity extracorporeal shockwave lithotripsy, we actually use low intensity. That was extremely useful in musculoskeletal issues, and physical therapists and orthopedic surgeons have used this for bone spurs, for tendonitis, etc. Later, what they realized when they were doing animal studies is that one of the major ways that this was helping was by inducing new blood vessels, which we call angiogenesis, but in the area that these shockwave was affecting. What's really good about it, once again, is non-invasive. I know this looks like a torture device, primarily when you're considering putting this near your penis, but I can tell you that we've used it in many patients. The discomfort is minimal, but it is kind of a weird sensation. That's what most people will tell you. So by creating this micro damage, or micro, you could say a little bit of a damage, what happens then, the body reacts by improving blood vessels, better vascularization of the area, and no wonder this is resulting in better erections in a lot of our patients. This is extremely useful as well in men who not only have prostate cancer, but may also have Peyronie's disease. Peyronie's disease is a disease where men will get curvature of the penis. You could think of it as some fibrosis or scar tissue that will deviate the penis, and oftentimes it's associated with decreased blood flow. So the shockwave has been extremely useful as well for this condition. One of the really good studies, and I'm sorry that it is very difficult to read, but I was really excited, was starting to look at how, because a lot of people, as you know, are undergoing some type of radiation, whether it's external beam or cyberknife or even brachytherapy, which is when we put those little seeds inside the prostate. One of the major complaints or major worries that we have is in a lot of men, even though initially they may not have impotence or erectile dysfunction, sometimes that seems to develop in the next year or two post-treatment. And as you can imagine, because a lot of you have gone through it, that can really affect your quality of life for you and your partners and your family. So trying to prevent this is extremely important. And then trying to salvage the people that are already suffering from it is even more important. One of the studies that we're trying to do in our facility is using this information. A lot of this information was done also with animal studies. And we are trying to develop a protocol and get funded. And we're already starting to do this in a number of our patients. We know that prostate radiation can cause nerve damage, and that's very important. We always had to assume that most of the damage was just vascular, meaning blood flow into the penis. But we now know that the nerve damage is significant and muscular damage as well. So any technique that we can use that is going to improve blood flow, correct the muscular damage, and then even improve neuronal damage, we can then reverse a lot of these people's conditions. If you look, I quoted here, the paper 65 and 67, this is extremely important because this is one of the experiments that was done in rat model, and they were using stem cells, and they were putting this in the cavernosa. So very much like what we do with the pea shot or the priapus shot, they were using stem cells in the rats, and what they found is that they could see an improvement not only on they were able to follow these animals, but what they could trace is that they could find that the stem cells did not just stay in the cavernosa, which are the two major aspects of the penis that contribute to the erections, but that a lot of these stem cells had actually migrated into the neurovascular bundles and even further proximal. And that is one of the ways that we think that this could be extremely beneficial in reverting some of the nerve damage that can occur with radiation. What's really interesting is that now people are using patches of amniotic cell membranes around a radical prostatectomy specimen. I mean, when we're doing a radical prostatectomy, we're using those around the anastomosis and the neurovascular bundle in order not only to protect them, but maybe to prevent, long-term erectile function. And also we know that sometimes even if erectile function will come back after a radical, it may take months to a year. So we're trying to see if this will facilitate and improve those numbers long-term and short-term. So definitely platelet-rich plasma and stem cells are fantastic in this respect. And then since we know that the shockwave technology can also improve muscular damage, this is going to address blood flow, neuronal damage, and muscular damage. And that's where I believe is going to be extremely important for our patients in recovering and hopefully even preventing going into these treatments, future sexual dysfunction. We know that the neurotransmitters are important. And what I wanted to tell you is, I don't care how together you are. I know for me, if somebody would come to me and say, oh, by the way, you have breast cancer, to be honest with you, I like to think of myself as being upbeat and easygoing and positive and all that good stuff that it's easy to be before we get really bad news. But once we're confronted with our own life, choices and the possibility of no life, that of course we're going to go into depressions, and depressions then can affect hormones. And so it's important to realize that during prostate cancer, during the diagnosis, during the treatments, that we have to be very mindful in how do we balance our neurotransmitters. There's no doubt that we have health care professionals that are, very good at that. There's psychiatrists, etc. But there are also some really good kind of little questionnaires that can help us identify whether you have a GABA deficiency or serotonin or dopamine. And that can really help us then help our patients to say, hey, guess what? I think that this is affecting you, and it's affecting your hormones, and of course it's affecting everything. Let's kind of support it and see if we can get you to feel better and take it from there. And lastly, well, not lastly, actually, one of the things that I wanted to point out very quickly is pelvic health. As you know, the pelvis is extremely important because part of the pelvis is the pelvic floor, and the pelvic floor is the urinary sphincter, but also fibers of the urinary sphincter will be fibers around the capsule of the prostate. So if we have dysfunction of the lower back and the pelvis, that's going to affect the ability of men emptying their bladders. It's going to affect their prostates, and it's going to create infection, inflammation. All of that is going to lead to prostate cancer or facilitate it. And it's also then going to contribute to symptoms during treatment and after treatment. So we need to be mindful of that. This is just to remind you that you see those little holes in the sacrum. This is the pelvis looked at from behind. Those little holes are sacral foramen. We had a joke in medical school, not a joke, but a little mnemonic to help us remember. We used to say S2, 3, 4 keeps the penis off the floor. And what that meant is that the nerves that are coming out of the sacral foramen 2, 3, and 4 are extremely important for obtaining an erection. And so this area of the lumbosacral area is huge in not only urinary function, but also sexual function, erection, ejaculation, sensation, etc. So men who are suffering from injuries to the lower back, L4-5S1, disc disease, etc., are going to have some issues, and those need to be addressed via physical therapy, osteopathy, chiropractic, acupuncture, any way that you may have available around you. One of the ways that we determine if that is present, other than by history and physical exam, is by using thermography, which is being used, we have used this in Europe forever, is a way of scanning the body that is quick. There's no radiation, and it's a good way for us to identify areas that are being affected. This is a study that we did with some of our prostate cancer patients, and what I wanted to show you is where you see that very red area is areas that are inflamed or areas that are not circulating very well. And what you can see immediately is the area of the ileum, the lymph nodes there, and also that's in the first picture. In the middle picture, you're seeing the lower back and sacrum. And the third picture, you actually see in the perineum, and notice that there is a lot of heat and inflammation or lack of good blood flow. And then what we did after the treatment, we did acupuncture and we did physical therapy. Notice that after 10 minutes post-treatment, there was not much change, but then after 25 minutes, there was a significant change. You get a lot more of a cooling effect. The blue is good in this case, red is bad. Look at the lower back, a lot of that sacral area now has good blood flow or is improving, and the perineum is definitely greatly improved. That was only from one treatment. So I think that, the more physical therapy, the more we can get circulation through this area, the better off we're going to be. And lastly, let's talk a little bit about endocrine health and testosterone, as you know, very quickly. And I don't want to spend too much time on it, but I want to give you a little bit of a enlightenment. There's still a lot of urologists and primary physicians out there that will tell you that that testosterone causes prostate cancer. I hope that a lot of you already know that that's not true. If that were true, then every 18-year-old guy in the country would have the biggest prostate cancer ever. We know that that's not the case. Prostate cancer develops later in age when testosterone levels go down and estrogen levels go up. Therefore, that becoming an estrogen dominance and not a testosterone dominance, more like a testosterone deficiency. It's funny how, things get taught to us by our professors, and they quoted their professors, and we've done that for generations. And unfortunately, we've been telling people that testosterone is the culprit. But thank God, over the past few years, we have more people now doing the right books, like Testosterone for Life, Dr. Morgenthaler, brilliant men who went back and looked at a lot of the old literature and realized that a lot of that was untrue. Testosterone in men, we know that, the levels decline 5% per decade. And unfortunately, guys, that starts at the age of 30, so watch out. We know that 50% of men over the age of 55 are already hypogonadism. I think these levels are getting worse. I'm not sure if that could be environmental, maybe some of the toxins that are also interfering with spermatogenesis. That means sperm production, maybe also starting to come into our water, excess estrogens and pseudoestrogens in our diet can do that. Anyway, it's important that we're mindful that can affect and compete with testosterone in men. Why do we even care about low testosterone? Well, low testosterone is important because so much of men's lifestyle, their thirst for life, their ability to overcome things, the excitement of being leaders, all of that is very testosterone dependent. And that is super important. The ability of exercising and maintaining muscle mass, the ability to recuperate from previous workouts, all of that is testosterone dependent. A lot of men that have low T are going to present with fatigue, hot flashes, decreased libido, so they'll just lose that excitement of wanting to be sexual with their wives and partners and etc. So it's super important to acknowledge that. Also, ejaculatory volume and also the tumescence, the firmness of the penis is also testosterone dependent. We know that men that are low in testosterone are more likely to develop prostate infections and prostate pain, as well as we suspect that Peyronie's disease is often associated with that. And now we know that men that actually have low T are at a higher risk for prostate cancer. As a matter of fact, there was a study that was done where men that had low T were compared with men with normal T, and they took into account racial groups and age and diet, etc. And when all of those were taken into account, what they found is men with low T already had 17% chance of having prostate cancer, while males who had normal T only had 4 to 5% chance. And I believe that this is one of the reasons why in the old days, when somebody was put on on testosterone, and then the PSA went up and they found prostate cancer, that is not that caused the prostate cancer, it just brought it out into the surface. So I think, in a way, testosterone is a way of bringing it out of camouflaging, and if it's there, it's better that you know. Most important thing to tell you about testosterone is that there is receptors for testosterone in the brain, and that's super important. Depression, social isolation, spatial memory, sense of well-being, assertiveness, all of those things which define a man, and that is very important for them in their work life, in their sports, etc. All of those are being affected. A lot of the anxiety, fear, and depression, a lot of poor men are being put on antidepressants when in reality what they need is to have their hormones balanced. So please, if you're feeling that way, go and see somebody that can help you figure out if that is the case. Other important things that people don't realize is that benefits also will improve heart. It makes the heartbeat stronger, the blood vessels get better, coronary artery disease decreases, it makes the blood thinner, more able to circulate. It can reverse insulin resistance, which is extremely important, because one of the things that happens as men become low in T is that their estrogens are they're going to become a little bit fatter. They're going to have more fat cells than muscle. Fat cells are notorious for making estrogens. Estrogens, as you know, are not good for men in that it will set you up for prostate cancer as well as other things out there. And that can also then kind of cause problems with insulin and then create insulin resistance, and then that can lead to diabetes, which creates more fat cells. And men just get into this crazy cycle, poor guys. On top of that, they lose that thirst for exercise, so all of a sudden they're in this trap. We know the benefits. We talked a little bit about it as we went. No doubt there is natural remedies. You need to eat enough calories. If you starve yourself to death, believe it or not, it's going to create a problem. It seems counterintuitive. Paleolithic diet, which means eating lots and lots of vegetables and fruits and good meats, but no carbs. Organic foods would be better. That takes away some of the toxins that we are concerned about possibly contributing or synergizing in the case of prostate issues. Amino acid supplementation, avoid caffeine and alcohol, avoid sugar and refined carbs, etc. Of course, use of tobacco and drugs are not very good for you. Chronic stress is a killer, so please start exercising. That will really help you. Just quickly let you know that hormones are very difficult to balance. Everybody think, oh, I have low T, so that's all I have to look at. No, remember that they don't work in isolation. There's other hormones that will stimulate them or block them. So you really want to work with somebody that knows what they're doing. Let me just very briefly now tell you how hormones and prostate cancer seem to come together. There's no doubt that now we know how beneficial testosterone can be in men, that we do not want to limit that in the right cases for our patients with prostate cancers. The whole thing started years ago in 1941, Huggins and Hutchins. There was other people that were the ones that, really wanting to help people without a doubt, but made some really big jumps in logic and gave testosterone a bad reputation. We know in animal models that as androgen concentrations, that means testosterone increases, that they reach the plateau, and no matter how much more testosterone you give them, you're not going to cause any growth of the prostate or any problem. So we know that prostate growth becomes testosterone independent at very high concentrations, at higher concentrations. So let me give you some of the papers that I think are going to be, that really helped me in trying to put it all together in my own mind. This is a great paper that looked at almost 1,600 patients, and they found no correlations between testosterone and PSA. Cooper studied, they used incredibly high doses of testosterone. If any of you are on testosterone, you realize that 250 to 500 milligrams a week is probably 3 to 5 times higher the dosage that you will ever need. And they were able to reach levels of up to 2,800 in the case of Bashan. I would have hated to be driving around when these people were driving around, but their point was well taken. These people knew that they were in a study, and they demonstrated it didn't matter how high they pushed, that the effects on PSA were none in normal patients. There was 19 control studies. We always criticize studies. Are they controlled? Are they not? Well, here you have 19 of them that revealed that no greater proportion of adverse prostate outcomes, and they were measuring that via PSA, no prostate cancer, were found when comparing the people that were in hormone replacement versus placebo groups. There were 21 longitudinal studies that were looking at the relationship between testosterone and prostate cancer, and that was never, they were never able to document such a relationship. They were looking also, they pulled 18 individual studies, and they came up with almost 4,000 patients with prostate cancer and almost 6,500 patients without it. Those are significant numbers. And guess what? No correlation between serum testosterone levels and prostate cancer. Men with prostate cancer did not have higher levels of testosterone. If anything, they had lower levels. So this is important because there's so much fear and is not based on science. Yamamoto et al. Looked at 272 men after radical prostatectomies, and what he found is that the risk of PSA failure at 5 years was higher by 2.7-fold in men with low T than in men with normal T. So if anything, this will show you, or this should give you an incentive to normalize your testosterone levels. These are different studies, and were some of the earlier ones, a combination of radical prostatectomy. Some of them were brachytherapy, which is the seed implants. Some looked at mostly those. And basically what you can see here is even after 12 years, there was never any evidence of recurrence in men that were in hormone replacement. And altogether, there has been, and this is old, I'm sure by now we can multiply these numbers by much more, but there's been 111 men and 1.8% who received hormone therapy at various localized, after various localized therapies, whether it was radicals or radiation of different types, and there was no evidence of biochemical recurrence. So this is it. I just wanted to show you and give you a little bit of peace of mind that if you are already in hormone replacement, that you're doing the right thing. And if you're not and you're having symptoms, please get some help and get your life back and start living and fulfilling your life again. Thank you for being here. If you have any questions, please don't hesitate to type them up. Otherwise, feel free to give us a call. My name is Emilia Ripoll MD, and you can go to our website, or you can give us a call at 303-444-0840. Looking forward to answering some of your questions. I have a question here in regards to how does testosterone interfere with blood clots. Let me make sure. Normally, it does not. It's like anything in life. If you overdo it and you have super therapeutic levels, that would not be a good thing. You basically want to come and end up in the middle of the range that is normal for men, unless you have already some kind of medical issue that predisposes you to blood clotting. There is natural anticoagulants for men that have prostate cancer, such as you can use nattokinase, lumbrokinase, fish oils. You could use, there's many things like that. What I wanted to let you know is there's no doubt that prostate cancer, primarily advanced prostate cancer, is known to sometimes cause blood clots, but that's usually in metastatic disease, not in early disease. And in those patients, you do have to be carefully followed, but not just because of testosterone, but just because that is what happens with metastatic prostate cancer. And then you need to be in some kind of fibrinolytic therapy. Another question, let me see, give me 1 second. Absolutely. One of the best ways to put somebody back and feel good that they're not going to have a recurrence is putting them after what we call definitive treatment. So if you have somebody who's already undergone brachytherapy, external beam radiation, CyberKnife, radical prostatectomy, those are the best people to put on hormone replacement without any fear. And the ones that sometimes is being a bit more controversial is people that are in active surveillance. There is enough evidence now that if anything, normalizing testosterone actually decreases the chances for recurrence or for advancement. So I think that's now well understood. Normal levels of testosterone vary with age. The most important thing is not just testosterone levels themselves, but the testosterone to estrogen ratio. If you look at young men and adolescents, the testosterone to estrogen ratio is 20 to 30 to 1. In men, when they get to 30s and 40s, they start going down to 10 to 20 to 1. You never want to fall between less than 5 to 1. That's considered estrogen dominance. And we know that estrogens are known to affect P53, which is a tumor suppressor gene. It's also thought to be involved with some of the oncogenes. So we definitely do not want to be estrogen dominant. We want to keep a ratio of 10 to 1 or higher. So if you are doing hormone replacement, please make sure that the people that are following you is looking not just on free and total testosterone and getting it to a mid-range, maybe around 600 to 800 or 900 for the total, but also that they're keeping up with your total estrogens. That's super important. Hold on, let me see what other questions we have. So Peter, yes, androgen therapy can reduce prostate cancer. We showed you the Yamamoto data on that. And so please, if you go back on, we're going to be posting this on our website, EmiliaRipollMD.com. So feel free to go back to the webinar and listen to it, and the answers are there. Somebody was asking me if I endorse testosterone and male enhancement. I endorse balancing your hormones if they're out of balance, because I do believe that low testosterone can affect men's quality of life. But I also believe that we have to be smart in how we do it, and that we have to follow people carefully. It's very safe in men that have already been treated, and if done properly, it can be safe in anybody. I'm a little bit more cautious with anybody who has metastatic disease, but even in these patients, there is now some newer protocols where we sometimes shock people with high levels of testosterone, but that's for a different talk. And thank you very much. I believe we run out of time. Thank you for participating and being so good about asking me questions. Thank you. Have a great evening, and I hope this was beneficial.